Hello and welcome to Triage, timely conversations for healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
Hello, I'm Andy Ruskin, a partner in the firm's Washington, D.C. office, and I'm joined today by my colleagues Darlene Davis and Gabe Scott, both partners in the Research Triangle Park office. In this episode of Triage, we'll be talking about CMS's new rural emergency hospital provider type, including recent CMS guidance that specifies the enrollment processes. Gabe, let's start with you. Can you please give me some background on the purpose of this new provider type and some of the key provisions associated with conversion to enrollment as a rural emergency hospital?
Thanks, Andy. So the rural emergency hospital provider category is a creation of the U.S. Congress and was established by Section 125 of the Consolidated Appropriations Act of 2021. It's been well documented that policymakers have had ongoing concerns about the financial health of rural hospitals for several years. And so this new provider type is really aimed at addressing some of the factors that have contributed to declining profits and particularly rural hospital closures in recent years. So CMS issued proposed policies for rural emergency hospitals in July 2022, and then finalized policies were included in the calendar year 2023 OPPS final rule, which, as our listeners know, was published in November of 2022. So while we don't have time to address all of the provisions applicable to rural emergency hospitals in this triage episode, the key threshold sort of enrollment provisions to know are: one, in order to be able to convert to this new provider type of a rural emergency hospital, a facility must have been enrolled and certified to participate in Medicare as of December 27th, 2020, and then be one of the following: either a critical access hospital or a rural hospital with not more than 50 beds. And then secondly, with respect to enrollment, rather than requiring this new provider type to submit a full 855 application, which would normally be required to enroll initially as a new provider type, enrollment as a rural emergency hospital is effectuated by submitting an 855A change of information application, which, if approved by CMS, then results in a conversion of the facility's enrollment to a rural emergency hospital.
Okay, so it seems relatively streamlined. Darlene, in light of Gabe's comments regarding this enrollment light process, are there particular enrollment-related provisions that have been identified as potential concerns?
Yeah, I think there are a couple items we can talk about, and you are right. CMS has tried to streamline the process, although, there is also a requirement for a transition plan to be submitted as well, which that, in the guidance CMS put out, more extensive guidance and FAQs CMS put out towards the end of January 2023, there's some pretty good details about what that transition plan has to have in it. But certainly in terms of the streamlined enrollment process, facilities will benefit from reduced administrative burden being able to enroll through a change of information rather than a full 855. However, that conversion process could potentially leave some facilities vulnerable if they convert to a rural emergency hospital and then they decide they want to try to convert back to a critical access hospital or a rural hospital. So this is really something facilities should consider as they are assessing whether to take advantage of the opportunity to convert to a rural emergency hospital. We've written a couple of client alerts on this new provider category over the past few months. And, we've emphasized in those alerts that the rural emergency hospital's ability to convert back to its prior category may be limited by a variety of factors, including such things as state certificate of need laws or licensure requirements. And in the OPPS final rule and the FAQs that I mentioned, CMS mentioned that essentially when you convert, it in essence terminate your enrollment as a critical access hospital or a rural hospital. And that results in the loss of any particular grandfathered status that was tied to those categories. So, for instance, that's particularly important for something like a critical access hospital that, may have had necessary provider status. If it converts to a rural emergency hospital and then tries to convert back, it may not be able to meet the distance and location requirements because CMS will look at that as an initial enrollment. And then in terms of the option to convert to a rural emergency hospital, state hospital licensure rules will likely need to be adapted to accommodate this new provider category. And states may move at different speeds to accomplish the changes they need to make to facilitate the ability to offer this type of provider in their states. So, for example, Arkansas passed a bill with broad support a few weeks ago that will allow facilities to change their state licensure designation to rural emergency hospital. And by contrast, the Colorado Hospital Association has noted that Colorado has to create a new license type before any Colorado hospitals could convert to rural emergency hospitals. So all to say, while enrollment as a rural emergency hospital is an available option now from a Medicare perspective, it's likely there will, be a period of time before we see a whole lot of enrollments in this new provider type.
All right, thanks, Darlene. So, Gabe, given that all facilities, but especially critical access hospitals, considering conversion to rural emergency hospital status, will need to be mindful of these consequences, what are the potential incentives? What makes it worth their efforts to actually go through this process of becoming a rural emergency hospital, and notwithstanding the gamble that it represents?
The reason why a facility might determine that conversion to a rural emergency hospital is appropriate, despite, as Darlene mentioned, the potential loss of grandfathered status, is that, rural emergency hospitals will be paid a monthly facility payment fee of nearly $270,000 per month. And services paid under the outpatient prospective payment fee schedule will be paid at 105%. So for facilities that currently furnish significant, outpatient services and that gain, sort of significant revenue from those services, recent reports, for example, one by the Chartist Group, found that outpatient services nationally account for about 76% of rural hospital revenue. So clearly there are some rural hospitals out there that do furnish significant outpatient services relative to the total services that they provide. For those sorts of facilities, the monthly facility payment and the increased OPPS payment amounts might result in improved financial performance. But, Darlene, as we've talked about, given that the rural emergency hospital provider category prohibits the provision of certain services that many rural facilities already provide, unfortunately, I think that, we expect many facilities to conclude that the extra payments probably aren't worth the trade-offs. Is that right?
That's exactly an area of concern and something that facilities will need to consider as they assess the feasibility and viability of converting to rural emergency hospital provider type for their communities. The conversion to this new provider type requires the facility, among other things, to maintain a 24/7 staffed emergency department. They have to maintain an annual average patient length of stay of less than 24 hours and forego the provision of all inpatient acute care hospital services. Facilities that convert to rural emergency hospital status would also no longer be able to operate swing beds. And of course, critical access hospitals would lose the cost-based payments that they receive today. And, significantly, there's currently no provision under the 340B drug program for participation in that program by rural emergency hospitals. So, now having said that, the regulations do permit a rural emergency hospital to have a distinct part that is licensed as a skilled nursing facility. So, it is still possible to be able to offer, SNF and NIF level services, although not as swing beds. But nevertheless, for many facilities, those are going to result in a number of structural and financial changes to, how the organization furnishes services, and, the financial changes will have significant implications from a reimbursement perspective. Gabe, as you noted, facilities that provide a substantial amount of outpatient services or that have a low average length of stay, they might want to at least take a look at whether the rural emergency hospital enrollment would be beneficial. Because for those types of facilities, the reimbursement changes could be less significant. But again, for many critical access hospitals and rural hospitals, giving up inpatient care may be a non-starter for their communities. And that's, even before getting to things like lost revenue from facilities that would otherwise be able to participate in the 340B program.
So that's a lot of headwinds that these entities have to face. Darlene,
Sure.
Do you think that CMS is aware of just how much of a challenge these facilities have? And if so, does CMS give these facilities the tools necessary to succeed?
It's interesting, and it will definitely be interesting to see over the coming period which types of facilities decide to try enrolling and sort of what that ends up looking like. Because we do know a significant percentage of critical access hospitals and rural hospitals have been struggling financially for many years. There's some recent data suggesting that the federal funding provided to rural hospitals during the COVID-19 public health emergency, may have made those facilities appear more financially stable than they really are. But I do think when Congress created this new provider category, there was hope within the rural health care community that there would be, kind of the potential for more broadly benefiting from a financial perspective rural health care facilities to help alleviate some of those challenges they've been having. But at least during this initial period, it seems like the impact is likely to be smaller, and maybe the focus will primarily be on hospitals that might otherwise have to close, and those being the types of hospitals that are really considering converting to rural emergency hospitals. So, if you look at it through that lens, if one of the goals in this sort of initial rollout is to benefit, kind of a small number of rural healthcare facilities that, that might end up otherwise having to close, then yeah, I think this new provider category, is helpful to those types of facilities. But, whether it's doing more broadly what Congress hoped it would, Congress may not feel that same way as we see what types and numbers of facilities take advantage of this. And if it doesn't, then, maybe we'll see some changes or refinements to the provider category that will encourage greater, facilities to take greater advantage of this option.
Got it. So for the time being, it's really more of a Hail Mary approach as between do or die.
Hail Mary indeed. And following up on Darlene's prior comment, I think it's instructive to view the rural emergency hospital provider category, particularly at this point, as one of the sort of many levers that policymakers are using or considering with respect to rural health. And so, in addition to considering each policy change on its own, such as whether, the conversion to this new provider category makes sense for a particular facility, providers involved in the provision of healthcare in rural areas will also likely want to assess the policy changes sort of more globally so that they can take advantage of the opportunities that are likely to be most beneficial for their organizations and their communities, with an eye towards all sorts of policy changes that are going on, this being one of them.
Yeah, I agree with that thought, Gabe. I mean, rural healthcare has certainly been in the news a lot, and I think it will continue to be for the reasons that we've talked about. For instance, recently there was an announcement in North Carolina that the state legislature plans to expand Medicaid, and that sort of announcement was delivered in parallel with commentary suggesting concerns from policymakers there might not be sufficient rural health facilities to meet increased demand that might generate. And I think policymakers are also considering, for some of the reasons that we've discussed on this triage episode, they considering changes to some of the restrictions on rural emergency hospitals to potentially allow for 340B program participation, or potentially to permit furnishing some inpatient services. So, all to say, we are likely to continue to see a focus on rural health. And, to the extent that includes increased flexibilities for rural emergency hospitals, it may be possible that this provider category will become more attractive to a greater number of rural facilities than we anticipate might be the case currently.
Gabe, Darlene, thanks so much for providing your insights into this developing issue, and more to come. This concludes this episode of Triage. We thank all of you for listening in and for letting us know if you have had some of your own interesting experiences considering the rural emergency hospital possibility.
Thanks again for listening to Triage, timely conversations for healthcare professionals. New episodes are available for download through Apple Podcasts, Google Podcasts, and Spotify. By subscribing to Triage, you will receive timely notifications for each new episode. Also, if you have any topics you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.